Hey, it's Dr. William. Grab your markers.
Have you ever wondered why
Lipo through the key area, round, fill in the hip, blend that into the leg.
I've got my pen and paper out today. I want to talk about...
Okay.
Yeah, okay, relax.
Welcome to my YouTube channel.
Hi, it's Dr. William. Welcome to my YouTube Live. Thank you for coming. And Nadia, I've got an answer for you as to why BBLs smell. And that's why I'm wearing this mask. This is actually the newest product we've added to the Ogee Recovery store. This is for your husband or your boyfriend or your spouse after you've had a BBL. This will help them be able to sleep with you to be able to tolerate the smell of a BBL. No, Nadia, BBLs do not smell. That's a myth. That was some clickbait that people come up with. But it's a pretty simple principle. If you don't wash down there, you're probably going to smell. If you do wash, you're not going to smell. But if you've had a BBL or not, it's not going to make a difference. You don't smell just because you've had a BBL. So that idea of smelling after having a BBL is totally false. So I apologize for missing y'all last night. It was technical error, not on my technical folks, but more of a technical problem with me. So we're one day late, but we're going to go through. I'm going to be talking about everything there is to know about a BBL. If you are patient enough to get through all this, then there is a gift for you that will arrive. This is the Ogee Recovery Guide to Having a BBL. It's a really good guide. I personally have written it. It has the Ogee Recovery Protocol in it, plus everything that you need to know before having surgery, how to pick a surgeon, what to do to prepare for your consultation, and then everything there is to know about all the recovery and all the things you have to do, complication, everything. So it's a really valuable guide. It's got a lot of information in it. I think it's very good information. If you hang on at the end, I'm going to be giving you a link to this guide. So let's get started here. And we're going to be talking about a Brazilian butt lift, a BBL. But the interesting thing is I'm going to be kind of doing this in a little bit different way than maybe you've heard before. I'm going to be kind of describing it as a story. And this is really sort of just my story in terms of as a developing surgeon, starting out as a baby plastic surgeon and then developing a lot of gray hair. And I'm going to kind of take you through what my story was, how I came to start to do BBLs and how I developed the Ogee technique. So it's going to be more of a story, and then we'll talk about all the complications. I've also got patients to show you. These are 3D models we're going to be going through. I've got a bunch of them over here. So we're going to have a lot of props. It's going to be, I think you're going to enjoy it. It's going to be fun. And let's dig in. Let's get started. Before I get started, I'm always curious to know where people are watching from, because I've got people that watch from places I wouldn't even imagine, and so it's really interesting to me. So if you can just put a little comment there where you're watching from, that'll be cool, and I'll be able to see those after. Okay, so with the Brazilian butt lift story begins, as you might expect, in Brazil, and Dr. Pitanga was the first one that developed the BBL, and that was back in 1960, if you can imagine that. And that's where he transplanted fat from somebody from one area of their body to the butt. And he's an absolute legend in plastic surgery. He's a huge icon. He's passed away not too long ago. He's really a hero in the plastic surgery community, and he taught thousands of people, and probably his least contribution to plastic surgery is the BBL, because he did so many other things. A really amazing surgeon. So it's very a simple operation. It just started and builds off liposuction, where we're taking fat from one area, and it's really a transplant. We're transplanting that fat. It's what we call an allograft, meaning it's going from your own body. If you take something or an autograft rather, taking something from one part of your body and putting it in another, it's your own tissue. So we were familiar with doing grafts, skin grafts, there's cartilage grafts, there's bone grafts. And so it was a natural transition for Dr. Patenge to say, oh, we can transfer all these other tissues, why not? So it was a natural transition. And we now know that fat is wonderful in that it's great for using it in the body, and fat is now used frequently in lots of plastic surgery operations. There's probably not very many facelifts that get done that don't also have fat grafting added to their facelift. So it's very, very useful fat, and it's not just for doing BBLs. So we'll just kind of go through my story as a surgeon. I'm going to show you some results. We'll talk about the 3D models because it's very difficult when you're looking at just a 2D image. You can see a change, obviously, but the 3D model is really nice because we can do that. And one of the people, Manuel, that works with me is able to render those images into these 3D structures, and then we print them. So it's really interesting. I think you'll get a different vantage point being able to look at those. We're going to talk about safety. Safety is always a big issue. Smell and safety are always the biggest issues, and safety is really no longer an issue with the BBL. I'm going to tell you why. We're going to go through some complications, and we're going to answer some questions as well. I'm going to answer the questions throughout the YouTube live, kind of to give you a break from me just monotone talking to you directly, and allow us to have a little bit of interaction. So there'll be time for questions. We'll have a couple of question sections. So let's get going. I'm going to tell you the story of my BBL story. It's what I call the Ogee story. So I have to go back to 1997, almost 30 years ago, when I graduated from medical school in Canada. And then I did general surgery training, and I went on to do my plastic surgery residency at Duke University in North Carolina, and that was from 2004 2007. And during that time, I saw Dr. Mendieta speak in Chicago at a conference. And I really didn't know anything about a BBL. We didn't do them at Duke. It was never really discussed, and it was certainly not popular at the time. And I went to see Dr. Mendieta speak in Chicago, and he was very funny and very educational. And there were not a lot of people at that conference. It was sort of a late in the day on a Sunday at the conference where a lot of people are already catching their flights home. But I approached him afterwards, and I say, would you mind if I came in and visited you for a week in Miami? And he's a very gracious person. He said, no, absolutely no problem. I'd love to show you what to do, because I just found it just fascinating to me that you could take this fat from one area. So here we are. There's Dr. Mendieta and with me back in 2006 or 7, I guess. And so here's a story. When I came back from Miami working with him, he's literally wrote the original book on how to do a BBL. He gave me a draft copy of his manuscript, which I read many times. And I was so excited because it was this concept of subtraction and addition. We're subtracting the fat with the lipo and then adding it. I thought that was wonderful. I didn't know of anyone in North Carolina that was performing the operation. And I waited a couple of years before I actually performed my first ones. And there were, I would say, quite a bit of negativity at the time. Other surgeons, either directly to me or indirectly, were like, why would he do that? Or why would someone put fat in the butt? And, it just seemed ludicrous to me, where there were sort of guidelines where it was fine to augment someone's breast, but it wasn't fine to augment someone's butt. And that just didn't make sense to me. But anyway, so I started off and I was doing lipo. And these are my early liposuction results. And I started to do lipo, and I was happy with my results, and I thought the patients looked good, and they were happy, and things were going along pretty well. And I used to do everything. Used to do, obviously I still do. Used to do chin, chin, and I did quite a few arm lipos and got some pretty nice results. And you start feeling pretty comfortable as a surgeon. You're like, oh, I'm pretty good at this lipo, and you feel more confident. And then this patient really here was one of the turning points for me, and sort of changed what I did. And so when I was looking at her before and after, I liked her result. Today it would be quite a bit different because we take a lot more fat today than we used to a long time ago. And it was when she came back for follow-up, and it was really this, honestly, when she turned around and did this and was wearing these underwear, and it just kind of made me think, like, gee, she probably would have looked better if I could have done a BBL. And I didn't talk to her about it. She never asked me about it. I wasn't offering them at the time, but it started me thinking a little bit. I'm like, aha, maybe I should start doing what I learned a couple of years ago and had been reading and following the literature. And so I thought, okay, let's start to do things. So I did, and I went in. This is my first BBL. It was terribly messy. It took me a very long time to do the case. I transferred to these very small syringes. It was very, very laborious, very time-consuming. And this was my first BBL. And when she came to see me for liposuction, she said, can't you use some of that fat and transfer that to your butt? And I'm like, well, you can, yeah. And she's like, well, maybe I should do that. And I said, well, I have never done it before, but I've studied, I've read, I feel confident that I can do it, but you have to know that you would be my first patient. For some reason, she's like, okay. And so she was very pleased, and I was very pleased with our results. And then I went on, and this was my second BBL, and I was happy, and she was happy, and it was really quite something to be able to, fill in the hips a little bit more and get a little bit more volume, and it was really very exciting. And, today I think I would get a pretty significantly different result, but at the time I was really pleased with this. And then all of a sudden, like everything in life, when you're on that learning curve and you start getting up, you're like, okay, I kind of got this now. Then I ran into a roadblock, and I had a problem, and I had a patient that was not happy with her BBL, and here she is here, and I see why she was not happy with her BBL, but I actually ended up sending these photos to Dr. Mendieta, and I said, I've got a patient, I thought I did what I needed to do, and she's not happy, and to be honest with you, I'm not totally happy, but I kind of didn't know what to do, so I asked for his advice, and he's like, well, you didn't really change her shape significantly. And so, that's a very sort of, as a surgeon starting out, that's kind of a gut-wrenching thing to realize that, perhaps you didn't do as good a job as you could have done, even though you're trying to do the very best job you could. So what I started to notice about her, and what she sort of told me and complained about, was that I really didn't take much fat. I really didn't change her upper part here. And so this was another patient that then came in, and so I thought, okay, well, I need to start taking a little bit more fat from that area. So this is really interesting, and this is phenomenal as a surgeon. As you go through, you really learn a lot from your patients, and also from looking at your before and after photos. So what I started to do is I said, okay, and if you could follow my little mouse here, this cursor, it's wiggling around there, and I'm going to put it now onto the patient. And you'll see that I was starting to develop my marking plan, but this line here, I took it straight across. So I realized I had to take more fat from that area, but I didn't know exactly how to do that, and so I kind of drew that straight and to try to target those upper areas, and I got what I thought was a better shape and a better result, even though I now realize that she actually had chicken butt. But we're gonna be talking about chicken butt, and I'm gonna be showing you a 3D chicken butt somewhere in here. Here, where is she? Yeah, she's over here. I'm going to show you some 3D chicken butt. It's really cool. And so, anyhow, I kind of started getting this concept of this key area. That became evident to me that if I lipoed more in that area, I would get a better shape. And so, you can see here. I mean, if I had taken a little bit more fat where I do today in the key area, then she would have had a better shape. So I started to develop this sort of concept in my own mind of this key area, but it's really fascinating to me if you look at my more modern markings compared to my older markings. So that key area, I kind of leveled that off where I was only going to take fat above. I was terrified of lipoing into the butt or getting closer to the butt, because that can be a tricky area, and it still is a tricky area to me, and I went through troubles learning the key area too. But now you'll see that when I do the key area, it really extends down, and that is vital and critical for getting that rounding shape to begin the BBL. And so, you know, when you're thinking and you're developing things, nothing's happening just one thought process that you're having. There's multiple thoughts that you're having, and then you have to kind of put them all together. And so at the same time, I was obviously still doing liposuction, but what I started to do when I did my lipo, I was looking at the result a little bit differently, and I was starting to not look directly at the patient. I was starting to look at what was the line, what was the silhouette that I was leaving. And so here's a before and after of a lipo patient here. And if you just forget about the patient and just look at her contour, I was starting to see the early form of the Ogee line that I didn't exactly have nailed down, but I really liked that line, and I started to remember a paper that I had read when I was still in residency at Duke, and it was a paper where they came up with the concept of the Ogee. And I didn't create the term Ogee. This is just something that I've adopted because it fits with what I do, and it fits with my vision as to what I'm seeing when I'm operating. And so the Ogee was originally, at least in plastic surgery, it's an architectural term that's very old, but in plastic surgery it was originally developed to talk about the face and talk about what they call mid-face rejuvenation, making your mid-face younger, and basically when your cheeks are dropping down, sort of bringing them up. And a surgeon was saying, we need to establish the Ogee, and that Ogee was in the face. And this was the Ogee. This was a concave part, and this was a convex. And so for people that lost mid-face, then they would bring it up. Well, how high do you bring it up? What do you do? And the surgeon said, well, just do it until you get this pretty Ogee. So that's where I kind of heard the concept for the first time, and it started to really make sense to me, and it started to fit with the picture that I was doing with my lipo with these silhouettes. And so I said, well, that's actually what I'm doing. And then at the same time, oddly enough, and this is where the story gets a little cuckoo, is I had taken 2 years off of the clinical work, and I was in the lab doing research, and I was doing a master's in genetics. And I had more time because I didn't have to be on call and doing all those types of things that I normally did. So my weekends were free, and I did a lot of gardening. And I took a gardening course at the local community center where I lived, and the person that was putting it on was a landscape architect. And he was there and wearing his flannel shirt and his blue jeans and his work boots, and he was teaching us some things about how to start a new garden, because I was putting a new shade garden in behind my house. It was a big tree and there was no sun there, and it was just an eyesore. So I said, let me put some bunch of hostas and stuff like that. So I talked to him and I showed him my plans. My plans for my shade garden is there was this big tree, and my garage was here, and my house was back here. And so I said to him, like, okay, so these are my plans for my garden. And I said, I've got a bed over here, and I want to run a bed like this. And then I'm going to put all these hostas in back here. And he was so funny. He's like, yeah, that's terrible. And I was like, what do you mean it's terrible? I think it's going to look nice with all these hostas, shade. There's no sun there. He's like, no, you got the right plants and you've done it. He said, but there's no straight lines in nature. And that really hit me like a ton of bricks. And so what he said is, he's like, you have to curve this bed. You can't have a straight bed. You want to have a pretty bed, you've got to curve it. And I didn't know, but as I was walking around the neighborhoods on the other side of Woodward Avenue, if you know Detroit, in Birmingham, Woodward Avenue separates sort of the not as fancy houses from the very fancy houses. My wife and I would walk with our kids in the stroller and stuff, and we'd go through and look at all these beautiful homes and all the beautiful gardens. And I started to realize after this landscape architect told me, oh, there's no straight lines in nature. And then I was looking at all the flower beds and everything else in these really nice homes that had professional landscaping, and they all had this thing. And I'm like, that's the Ogee line. That's a line that's really pretty. That's why these look nice. Oh my God, the Ogee is everywhere. And that's how I really came up with the concept of this Ogee Lipo in order to get these shapes. And it naturally fit in with what I was doing with the BBLs, because the Ogee shape that I originally sort of thought about was really just more of that concave when I did the lipo. But then when I started to really do the BBLs, and I realized, like, oh, that's the convex part. And so then it all started to kind of fit together. And so that's the concept of the Ogee. So I'm going to show you some results here, and we'll go through a few of these things. And just to kind of, what I want you to do when you look at these is just kind of look what I'm looking at, and almost ignore the patient, but just look at the outside. And you'll just start to see Ogee line after Ogee line after Ogee line after Ogee line. And everyone has an Ogee line, and everyone's Ogee line is different. And that's the exact reason why wish pictures are not helpful. They're not useful, because your Ogee line is different than the next person's Ogee line. It's there, everyone has them. Some Ogee lines are better and some are not, but everyone has one. There's differences. If you look at the Ogee line itself, you can stretch, sometimes the concave part is longer. In this situation, she's got sort of that longer upper torso, so that's going to look differently, but she still has a nice, pretty Ogee line. And so we can look through from front and back, and you'll just see this constant line. It's always there. So now whenever I do lipo and do the BBLs, that's really just what I'm focusing on. And when BBLs kind of really became a craze and took off, I was doing quite a bit of surgery, obviously, but I was not someone that did the big butts. I never did these just big butts because I didn't like it. I didn't think it looked good. And I was worried, what is that patient going to look like in 20 years if I just stuff a bunch of fat in? So I just started to do a natural shape and just started to follow the Ogee, and everything just started to fit together. And you'll look at these patients, and sometimes you think like, oh, that's the same photo. It's not. It's a different photo. It just happens to be that they have a little bit more similar shape, but not exactly the same. Here's somebody who has a remarkable change. In fact, she has chicken butt. And so if you've never heard the term, I didn't coin the term chicken butt, but it's applicable. I've got some dust from that little mask that I was wearing. If you missed that, I don't know how it looked, but it kind of felt funny. Okay, so chicken butt. Chicken butt is where in the lower part, the lower middle of the butt, so it kind of where this black line is, you have typically a flat crease, and then it hangs down like that in the middle, and then that sort of goes up, and then you have the same thing on the other side. And that's what's called a chicken butt. And it's hard to completely correct it, but you can improve it. And so let me talk about the chicken here. Where is she? Here she is. This her here? Yeah. So this is actually this patient that I'm showing you here. I'll show you from the behind so you can see her same angle. Is that good there? Yes. And so this is her picture. This is the same photo in 3D that's been rendered. And so it's always one thing to see just a static image, but here she is here after. And so you can see her before, and here's her after. And so she has a different Ogee shape. and she got a pretty good correction. If we look at her, could you put this on the overhead? So if we look at her, here's her before, here's after. It's pretty easy to tell the difference. She had a lot of external fat here. None of this has been airbrushed or touched up or whatever. It's strictly renders from the photos. So you'll see her rolls and some skin and creases and whatnot. But if we look down here at this bottom part, you'll see where the fat went. And it's to me, it's kind of fascinating to look at my results through these 3D models, because I don't ever have the patient lie on the floor and then stand above them and look at these areas. When I'm operating, they're in that position. But when they follow up and see me after surgery, obviously they're standing up on my little stool. So it's kind of interesting because you can really manipulate these and start to look. So for me, these 3D models have kind of helped me and reinforced some of the things I do. So anyhow, but if we look here, so when you put the chicken, I'm going to just kind of move these apart. Do you still see these on the,
Move it a little more towards,
like this?
yeah.
Okay. So, are we still good?
Yeah.
Okay. So, when you do a chicken butt, you cannot inject in this location here, because all you're going to do is you're going to make that chicken butt worse. And this tissue here will also expand very easily. So, if you put even small amounts there, you'll get quite a big amount of fat there. So I don't put any fat there. That's going to make the chicken worse. And what I try to do are in these tight areas here, where the reason why that little piece is hanging down is because it's tethered up higher. And so this tethering, which is right in this area here, and then I look here, I'm like, oh, did I really improve it or not? And then I start to look like, yeah, because I know that I can't put fat in here, so I didn't put any fat in here, but I can bring the fat out in these other areas here. And to be honest, I'm really pleased. I mean, I thought she looked good in the photos. I thought she looked good when I saw her. But when I look at the 3D model, I'm like, okay, this is good. I did the right thing. I put the fat in the correct spot. And while it doesn't totally get rid of the chicken butt, it kind of minimizes it and improves it. So one of the things that I do want to talk about is when you talk about this tissue here, that original chicken tissue, that it's very easy. Remember I said it's very easy for that tissue to expand when you put fat in. So I think most people, now guys grab me if I black out here, but most people think when you're doing a BBL that when you put the fat in, the tissue is going to just respond like a balloon. Like everything will just uniformly expand. It doesn't work that way at all. There's all different areas of what we call tissue distensibility. So how stretchy the tissue is. The area of the chicken, super stretchy. So just like blowing up this balloon, you put some fat in it, it'll just blow up. Other areas, particularly that can be, and somebody who has very tight hips, that you can't just put it in and have it blow up. You put it in and it can just stop. The tissue's just hard and you can't get it to expand. So when you think of a BBL in your mind, you're probably thinking that, oh, it's just you put the fat in, everything goes and the way you want it. It doesn't. There's all these differences in tissue distensibility. So that's just a general point to know anyhow. So, okay. So let's go through, and I'm going to just show you a few more results here, because I do want to get to questions, and I want to get to complications, and I want to get to recovery, and all these other types of things. And I don't want to just focus on results, but I know people want to see results, so we put them in here, and it's fun. So these are just, again, not really specifically looking at the patient, but just the general concept of the Ogee. And this is a skinny BBL. Here you can see she has a very tight waist. In fact, I can show you her 3D too. I've got her 3D. Where is my skinny BBL here? Where is she? Here she is. So now, if we look, here she is, and I'll put these photos in this way here. So here's her before, here's her after. And she had a very small waist to begin with. Her waist is smaller after surgery because I removed the fat, but her main fatty deposit were in these very heavy areas. And it happens to be a lot of it in the key area, which for me, my eyes light up when I see someone with a really small waist and a lot of fat here. I call that the winning combination because we get significant changes as we have here. But if you see her silhouette, I mean, I really want you just to kind of look at the outside, look at those lines. And so if you look at her silhouette, you see how it's kind of wavy? So what I always do, and when I'm explaining to patients, I always kind of start down here in the leg, and I say, well, okay, well, look at this line. And this line here is really nice in her. So she already has a really nice line. So all I have to do is feed off of that line. That's kind of like my anchor point. And that's going to be where the Ogee line is going to come off there. So I say, okay, well, this line will come up, but where you have your hip dip, I'm going to put fat. Remember, when you're treating a hip dip, you really don't just put fat here. Well, where am I going to? Here? One?
Yeah,
Okay. So you really don't just put fat here because the fat, the hip dip goes all the way back. You can see it. You can see it in there. I mean, can you see it?
yeah.
Okay. So you can see that the hip dip is not here. It's why you just can't go and correct a hip dip by putting a little bit of fat here, because the hollowness goes all the way back. I mean, my finger's in a groove here. So you have to graft back in there. So I say, okay, I tell patients, this is the goal. I can't guarantee we're going to get here because it's going to depend on how stretchy your tissue is or how not stretchy it is. But the goal is always to get the Ogee. So I say, all right, this is a nice line, but I don't want this line to come up and then go flat. That doesn't follow the Ogee. I don't want this line to come up and go flat and then come out. What I want is here, and we were able to end up with a nice result here because now I'm saying, okay, here's her leg coming up. This is nice. I did add a little bit of fat here to this part of the leg. This is kind of a transition point because I just want this line to be perfect. So if I feel that there's a little bit lacking here, then I'll put a little bit. And you can even see, and this is why these models are just wonderful, because there's a little bit of loss of fat here. So I put a little bit in here to blend it. And then it's just a matter of this coming up, and now we filled in the hip, and you can see that that's now got fat in it, in the butt, where she didn't have fat here, and that's all part of the hip dip. Hip dips always go way back. And so now we want this coming out, but when she has this part up higher coming out, that's what I want coming in. And so it's just coming like this, and then it just goes right up, and it goes all the way up to the back. The Ogee line, when we do the lipo, I don't want this line just to come up and stop. I really want this all the way up. That's what really gives you a nice, natural, pretty shape. And if you look at her from the front, here's her before, and here's her after. And again, just focus on the line. And the line is to me anyway, really pretty. It's always tell patients, if you're looking for a surgeon and you like the general shape that they do, then that's your surgeon. But I realize not everyone likes the Ogee line, and that's fine. It's not everyone's cup of tea. And I've had patients come and tell me, like, well, I don't want you to lipo through that area. And I'm like, that's kind of where I lipo. So I'm going to be doing something different than I would normally do, and I don't know that that's going to really look good. And I say politely, if I can, to say you may be better off with a different surgeon that's going to do that, because when I look, you can't operate with someone else's brain. You can only operate with what's in your mind. I mean, if you're cooking a meal and you're cooked that meal a lot of times and that's the way you make your meal, and then the other mother-in-law comes in and she's like, oh, well, I do this, this, this. Like, okay, maybe you do those things, but this is kind of the way I do it, and this tastes good, and this is what we're used to. So, but that's the shape. That's always the shape we're going to. That's kind of how I came up with the concept, and I've just stuck with it. And I for me, it looks good, and so that's why I continue to do it. So, okay, let's put her away. And I'll go through and show you a few other results. This is also someone with I call the winning combination because she has heavy deposits up top, but look at how tiny her waist is. And so that always gives a pretty stunning result. Projection is usually fairly normal, what I think is normal. It's full. I like to say I'm going to give you a little oomph, but I don't like it just overdone. And it's hard to reduce a butt. And I saw someone recently who had a pretty good shape, but she just wanted her butt smaller. It's really difficult to just shrink the butt and keep the same shape. So if you get too much fat put in, that can be problematic. So here's another patient, same kind of concept. Here she is here. So I'm going to show you here. Here she is before. Let's turn it this way. Here she is before, and here she is after. And I'm not going to go through it in so much detail as I just did, because I think you probably got the concept already. But just do what I do. Just look with me, and here's this line. Just follow that line. You see how this is wavy? It's just going up and down. I said I'm not going to go through it in detail, but I can't resist. So here it's coming in here, then it's going out, then it's flat, then it's coming out. Well, that's not that nice smooth Ogee shape. So here we are. She's coming here. You can see, I don't know if you can see, if you can appreciate this, but she had a nice little fat pad here. I call this the egg salad. You come to a picnic, you show up with a nice egg salad. Everyone's loving you, as long as you haven't left it in your car overnight. Then you've got a little fullness here. That's great. I love it because I can build off of that. And so in this case, here she has a little bit of fat. I had to put a little bit of fat down here. This may be subtle to show on the camera, I'm not sure. But when I look at this model, I see this coming up and kind of being really pronounced here. And I want it just a little softer. And so put a little bit of fat in her leg to blend that in. We want everything. People think BBL is just operating on your butt. It's not. It's operating on a large part of your body. And so put a little fat in the leg to feed off that egg salad that's in there. Fill in her hip dip, and you can see she's quite flat. That other patient I showed you had more of a depression, and she's a little bit more flat. There's a huge variability to hip dips, which we won't go into. But anyway, filled in the hip dip, and then this fullness up here took that down. And so again, just trying to get that line. And that's all what it is. And then once I get the hip dip filled in, then I add the volume based on the hip dip. So the volume matches the hip. So everything matches. And so she has a really pretty result. Oh, this is really interesting too. This is really interesting. She is not the same on either side. I don't know if you can see that. So for her, sorry, I got to turn around. So this is a really good case of asymmetry. And you can see it in the photo. Let me show you in the photo first. Look at my mouse cursor here, over above where it says Ogee BBL. Now I'm going to take it all the way to the other image. So now I'm over here. And I don't know if this is too subtle or not, but you can see that this side here has some more kind of flatness than this side does. And so you can actually see that in this model preoperatively, where this side is a little flatter than this side. It's a different angle. So this side of her body is kind of coming in a little bit more, a little flatter, and you see that in her in her result as well. If I look here, and that's why the 3D models are awesome. I get to somebody comment, please. Every time it says 3D model, have a shot, because I love when people say stuff like that. So, and I can see asymmetries here, and I can see imperfections. In fact, if I'm looking straight down here, I see this butt is projecting more than this one. no one will look exactly the same from side to side. And this one here is flatter because she had a little, let me see if she has more projection. She does. That's awesome. She has more projection here. Let me see if I can show you that. I don't know if I can show you that or not. Let me see. I'm going to need a little help, guys, telling me if you can see this or not. Can I hold that up? Can you? It's going to be kind of hard to see from the angle. But she's got asymmetry. For sure she's got asymmetry. And if she came in and said, well, this butt is a little bit flatter here, you know, if this person comes in and she says, well, this is a little bit flatter, it's a little bit thing, what I say is I go, yeah, you're absolutely correct. But she looks fantastic. These are subtleties that surgeons that sit on stools see, or that patients that look in mirrors after surgery will see. This person looks great. I think most people would agree, like, wow, she has a really pretty body. It's asymmetrical. Yes, it is. One side a little flatter, one side projects a little bit more. These are subtle things that are really beyond our ability to completely correct. And they don't need to be corrected because they're not broken. They're just normal asymmetry that we all have. But the take a shot 3D models will help show you these things. Again, Ogee, you can see she has a different shape, totally different shape, her Ogee line. But everyone ends up with the Ogee. Okay, I don't want to belabor this. I think you kind of get the idea of the difference in shape changes and the Ogee concept. So let me take a break here and let's take some questions. And then after that, we're going to talk about safety and BBL safety. So I'm going to show you using this. Take a shot, 3D model. Not you, Frankie. If you're watching, I don't want you taking shots. We're working tomorrow. But I'm going to show you here with this 3D model and also some ultrasound images on the safety. But if you have some, is this a good time to stop for questions? You have the iPad? Let's take a few questions, and we'll start there. And then we're going to go on and we'll talk about safety and fat emboli, and probably most people don't realize, but a BBL now is a lower has a lower risk than a tummy tuck. So okay, what am I going to do? Just scroll on here. Yeah. All right. If someone needs a 360 lipo with a small butt lift, no extra fat, which procedure would be best? Ogee lipo or BBL? I don't understand exactly. Okay, well, there is actually videos on my channel comparing just lipo to a BBL, but I'll explain it to you here. And let me also say one thing, and that is, I saw someone today, perfect example. I saw someone today, and she had seen another surgeon, and they said she's not a candidate for having a BBL. She didn't have enough fat. And I saw her, and I thought, like, she has plenty of fat. And I think that's can sometimes be confusing, is I think people think they need a lot more fat than they do. And the volumes of fat that I put in to get the shapes are probably smaller than what you would imagine. And so even patients that are really thin typically have enough fat. But anyhow, if you don't have enough fat, there's a couple of options for you. You can just do lipo. And so if we just do lipo, let me see, where's one of these people here? Okay, so let's just say, this will be a good example. Let me move this little model, which we're going to look at in a moment. Here we are. So if you just do liposuction, then it's the exact same lipo. If you do lipo 360 or you do a BBL, the lipo, identical. The only difference is with the BBL, we're transferring the fat. With liposuction, we're discarding your fat. And so let's just say with this patient here, Well, here she is with her BBL. But if I didn't do a BBL on this patient, then all of this would have been removed, and she would have had about a smaller waist, even though her waist is really small. All of this would have been removed, but none of this would have been filled in. So that's really the difference. Is with a just Lipo 360, your butt will look larger because we're making your body smaller, and you'll have that nice part of the concave part of the Ogee. If you naturally have a really nice convex part of the Ogee down here, then I tell people you don't need a BBL, just get Lipo. You're going to look good with Lipo. I mean, I say sometimes, I say frequently, the best BBLs I do are the ones I don't do. I just do Lipo. So if you have really nice here, but if you have hip dips or something you want corrected, or you do want an increase in size, then that will push you over to a BBL. Now, if you don't have enough fat, even though I said I can find fat on a lot of skinny people, there are options, and there are fillers. I'm not an advocate of the fillers because I think there are problems with them, and also it doesn't even conceptually make any sense to me. Just in the volumes that you use, I don't do any fillers anymore for lips or anything like that, but I used to a long time ago. And use Sculptra, for example, and I'm using prices that are maybe outdated or maybe not, I don't know. But I think I remember that the Sculptra we used to cost $1,500 or $1,700, what we used to charge patients for a syringe of Sculptra. I think it was 1.75 cc's. And so we'd take 1.75 cc's, maybe put it under the cheek on each side and things like that. And so that was expensive, $1,700 for 2 small syringes. So I don't see how on earth you can possibly fill in a hip dip and not have it cost you $250,000, because it doesn't make sense from a volume point of view to me. So I don't recommend the fillers. There's a new product that's coming out that actually is fat, and it's called Alloclay, and it comes as this is not the fat, but these are just some mock-ups that were made using some type of 3D printer, and they just come preloaded. So if you absolutely don't have any fat and you want to make some corrections, I think your best bet. It's early now. I don't have a lot of experience with it, but from what I understand and their science behind it is this is cadaveric fat. This is true human fat. It's from someone who's obviously passed on, and that can be used for somebody that just doesn't have fat. And I also have some other examples I want to show you where I think this product is going to make a difference, and I'll show you that later on. Okay, one question. I need to pick it up a little bit here. Okay, you're from New York. I like that. Marisha says, is J plasma worth getting? Depends on who you ask. If you ask me, I say no. If you ask other people, they say yes. J plasma in a lot of these techniques are designed for tightening the skin. And I think what's happens is patients are probably a better candidate for a tummy tuck, but nobody wants a tummy tuck. So what happens is things get developed and they say, well, if you don't want a tummy tuck, then you can use this to tighten your skin. And so it's like having a tummy tuck, and then it'll remove the fat. And then you can have the best of both worlds, because you can get your fat removed with lipo, and instead of needing a tummy tuck, we'll tighten your skin. Doesn't really work that way. Definitely does tighten your skin, but not in the way that you kind of would want it to tighten your skin, in my opinion. And that is, when I think of tight skin, I think of this. So if I do a tummy tuck, I get rid of that skin and I pull it down, I can get people to have nice, flat, tight skin. With other techniques, you get more of this type of thing, where you're not removing the excess skin, you're just shrinking it. So it kind of shrinks, just it gets a little crepey. So I think the skin tightening part, does it work? Yes. Is it kind of the way we expect or want? In my opinion, it's not. And the other reason that I really don't like it is because it generates scar tissue, and scar tissue leads to fibrosis. or that's what it is. It was fibrosis, and everything that I do, this whole thing here is based on trying to get you, and we're going to go through that later, is trying to get you the very best skin. So my focus is on getting you the best skin, and I don't like J-plasma for that. Hello, Boston. Can you do arm lipo and transfer to the buttocks? Yes, you can. Usually not just arms. Usually you have to include some other areas, but particularly for people that are very thin and we are looking for fat, arms can sometimes be a source, and definitely. Tennessee, Phoenix, Bendu. My in-laws live in Phoenix. My wife grew up there. I was like, where are your fiber guard? And I realized, oh, that's us. Okay, Puerto Rico, Jersey, Indiana, Florida, whoop, whoop. Maryland. We have a lot of patients from Maryland. Both of my kids go to school and go to college in Maryland, so we're up there all the time. MFG is asking, can scar tissue from our lipo be fixed with fat transfer? Maybe, potentially. That's also maybe an area for something like this alloclay, where you don't have to have liposuction anymore. We can just literally take this out of the package. So fat is good for correcting irregularities. So if you've got like what I call the shark bite arm, where you had lipo the arm, but they really just only lipoed here, and then you got fat up here and fat down here, it just looked like a shark bite. Well, you can re-lipo those areas, but you can also, if you have like a lot of, let's say you had reasonable lipo here, reasonable lipo here, there's no real fat in these two areas, but you still have the shark bite. Well, you can't take more fat from here and here to even that out, so you can add fat. And that's probably where alloclay will start to come in as well, is correcting some of these contour irregularities. And I have another model to show you where it can be used for divots or dents in people's buttocks. Oh, Rhode Island. Love Rhode Island. Massachusetts, Georgia, Lubbock, Texas, Austin. I think I've been to all those places. I don't know if I've been to Lubbock or not. But I've definitely been to Texas a few times. Austin is a beautiful place. Okay. Nicole, how are you? Don't stalk me, Nicole. We're going to get a restraining order. Oh, look at this. Puerto Rico, St. Mark, Jamaica. I love this. Thank you so much for telling me. Canada. I came from Canada originally. I grew up in Vancouver. Went to school in Ontario for medical school. Okay, here we go. Jolie V are you supposed to put foams on your hips in the faja? I just had my BBL. I'm scared to overcompress. So where we use foams is basically foams are on the side, boards are in the front. Why are we using boards and why are we using foam? So that's the first thing you have to kind of to address. We're using boards which are stiffer and tighter, and they go under the faja. We're using a board in the back to apply compression. We want compression there. We want compression in the front. Why do we want compression on these two sides? We really don't want compression on the sides in as strong a manner as you do get with a board, because these two areas form seromas. That's where you get a fluid buildup between, I can show you actually on our little model here. It's going to be on the overhead. And I'm going to be using this model to talk about safety in a moment, show you where the fat goes and all that stuff. But here, if we remove the skin, here's the fat, and a seroma is where you get a fluid accumulation between the fat and between the skin. Now, it doesn't happen in the butt, so don't think that it happens in the butt. I just wanted to show you between the skin and between the fat, that's where seroma happens. But it happens most frequently in the small of the back and in the front. And it happens both in the lower areas because it's dependent, so the fluid goes down and collects lower. Now, Why in the back? Well, this area is what we call seromogenic. It likes to make seromas. Well, why? Because the skin is trying to stick down, but in this area you have very thick, strong fascia, which is like a very thick leather belt. And trying to get the skin to stick to that leather belt is more difficult. In the front, the skin is sticking down to the fat, which is easier to get those two to stick together. But we want the boards to compress, so we get those two surfaces in the front, the skin to the little bit of fat and fascia in the back, and the front, the skin into the fat. We want those to compress, and we want to limit the space for the fluid to potentially collect. That's why you wear a board. You wear the board for 2 weeks because that's the time where you can form seromas. So we want the compression during those first 2 weeks. If you haven't had a seroma at 2 weeks, it's unlikely you're going to develop a seroma. Possible, but pretty unlikely. And then the foams, they're going on the sides and can be in the upper abdomen. Your board's going to be in the lower abdomen. It's going to go in the upper abdomen, and you're going to have the foams on the side. That decreases swelling. It decreases bruising, actually. Arnica does not. Come after me. But foam has been shown clinically to reduce bruising. And also, nobody's faja fits them perfectly. Look at all the different shapes that I've been showing you here with all these different shapes. And you're not going to have a faja fit every single one of these people exactly perfectly. So the foams will go in there and kind of can fill out. If you have a little gap between your faja and your skin, the foam can fill in that gap. Foam, aside from the bruising and the swelling, provides you comfort, and it also can prevent a crease from the faja kind of being transferred over to your skin. So those are the reasons we use the foams. We wear them under the faja, and we wear them in these locations here. So boards in the front and back to prevent seromas, foams on the side, comfort, bruising, swelling, prevent faja creases. Both of those I recommend, at least for my patients, wear those for 2 weeks, and then we switch over to the FibroGuard because, again, it's focusing on skin. We want that to be the best. Okay, let me get back and resume this, and we'll still have time for more questions later on. But let's talk about BBL safety now. So the whole concept of BBL safety relates to what we're talking about as a fat emboli. So if you get a fat emboli, what that is that's fat that gets injected into your butt. So let me show you on this, and then I'm going to show you some diagrams. The fat can get injected into a blood vessel in your butt and travel up to your heart. And did that show up? Okay. And here's an example. So can you do a split screen where we can see the slide and also this camera? No, okay. So where are we looking at right now? This overhead?
No, we're looking at the slide and you as well.
Okay. So, all right, let's look at the slide. So if you look at the slide, and it's going to show you, follow my mouse here. So here's the skin here.
Oh, I can do that then.
Yes?
Yeah.
Split screen?
Show the slide and overhead.
Okay, perfect. So these kind of fit together. So if you imagine, here's the skin, and then underneath the skin is the fat, and then there's a layer of fascia. And so the layer of fascia is this kind of dotted line that I've drawn on the slide. And then you have a deep fat. So this fat here is a superficial fat, and then you have a deep fat, and in between these two you have a little bit of fascia. When I do a BBL, we always inject in the deep fat first, this fat. And then I inject in the superficial fat. And so here's the, I'm gonna tip this over. And then below that is the muscle. And so if we now look at the same diagram, and we look here, when I originally learned to do a BBL, we were taught, and everyone did it this way, is to put fat where these little circles are. Above the muscle, okay? So in this fat, above the muscle, right here, in that fat above the muscle, and that also included this fat layer. And then in the muscle itself, so then we actually put fat into the muscle. Why would we put fat in the muscle? Because the muscle is a really good place, good blood supply, nice and warm, cozy, comfy, and then the new fat grows in there. And then we used to put it below the muscle as well. So those three places. In the fat above the muscle, we used to put it in the muscle, and we used to put it below the muscle. And what we found out is, oh boy, it's dangerous to put it in the muscle or below the muscle. Because if you look here and we go below the muscle, these are where these big, large blood vessels live. And if you look now on my slide, and if I'm putting fat down here and I'm injecting it into that vessel, to that large vein, that globule of fat can go right up to your heart, and your heart will pump it to your lungs. And that can give you a fat emboli, and that can be fatal. Fortunately, I've never had one, but I never will have one because I know exactly where my fat goes. That's why I mentioned earlier that the safety or risk profile of a BBL is actually safer than a tummy tuck, despite all the comments people will make like, oh, thankfully you survived that most dangerous operation. Well, a long time ago it was dangerous because we didn't know where the fat was going. Now we can see with the fat, and this is what the ultrasound looks like, which to you may not look like anything, but here I've kind of identified things a little bit. So if you follow me here, along with this little model here, where I'll go through the different layers with you, and you can see it on the ultrasound. So if you look on the ultrasound, the first pink dot at the top where it says skin, that's what shows up on the probe, because we're running the probe on top of the butt. So we can see the first thing we see, where we've got the probe on the skin, we see the skin. So there's the skin. Then the next layer is that yellow dot. It says subcutaneous fat. So that's where you see this more superficial layer of fat. Then there's a layer of fascia. In between these two layers of fat, there's a layer of fascia. And then underneath the deep layer of fat, there is the muscle. And the muscle is covered with a deep fascia that's very thick, and that's what's got this rectangular box on it. So we know, and then underneath you see the pattern of the muscle, these striations. So we know that if we go below that bright white line, we're going to either be in the muscle or we're going to be below the muscle. And below the muscle is where these large arteries and veins live. So it's dangerous to put fat in there. So, but it's easy to see. It's a very bright line. And for people that have even never done ultrasound, I mean, you can see that that's pretty easy. So I can watch my probe, where my cannula in real time with my ultrasound probe, and I can actually see where the fat goes. And so I know exactly which level I'm in because it's clear as day. And here is, if you look at the slide, this is here. This is showing here where the muscle is down low, and there's a bright line of fascia, and this is where the fat is. And so I can actually see in real time, I can see the fat coming out of the cannula. So that's why a BBL is safe. So, okay, we talked about chicken butt, so I'm not going to talk about that again. We talked, I showed you the model with filling in the hip dips. We talked about the skinny BBL. Let's talk about a divot or a dent. And working in Miami, I obviously operate on a lot of patients from Cuba. And in Cuba, the doctors, when the kids were little, it was quite common to give them either a steroid shot or an antibiotic into their butt. And they didn't know that when they would grow up, they would still have that scar. And so there are quite a few people walking around with these little scarring. And so I'll see them and they'll say, I'd like a BBL. And one of the reasons is they want to improve the dent. So I'm always very cautious to tell them I can improve it, but I cannot completely make it go away. Although I do think that this is a opportunity for alloclay again, but we'll talk about that here. So here's this patient, same patient here, and you can see with her divot. Sorry, this is actually I think this is a different patient. My bad. So with this, you can see, I'll show you here. Here she is before, here she is after. So this is a real patient. And you can see that the divot was fairly pronounced here. And it's better here, but not completely gone. So this is where I think having another injection of fat or probably just alloclay to go into that divot to see if a more fat can go in. Because when I've done 2 rounds of BBLs on patients with them, I always get more correction the second time. And I also will release some of the scar, meaning I'll cut it underneath the second time. I don't like to do it the first time because I've done that and the patient ended up with a big oil cyst, and it happened to me a couple of times, so I stopped doing that. Because originally you really want to go in and say like, oh, let me just release all that, and that'll have that skin just pop up, and then I'll just put fat in there. Seems like it would work. I can tell you it doesn't. So I'll do the best I can without releasing the scar tissue, but sometimes a second go around, then I'll do a little bit of release because they've got some fat and they've got a base, and it's less problematic. So you know, that I think is going to be something for an Avali, and which is a little device to cut cellulite bands, and Avali and alloclay, or Avali and your own fat. But for people that have had lipo and they don't want to go through it again, they don't need it, they already look good, they just got to fix the dent, that's when you can use an alloclay where you're not having to harvest the fat. It just comes loaded, and then you can just inject that. So, okay, let's talk about a few complications here. And one of them is something called fat necrosis. So I hate fat necrosis. I have patients with fat necrosis. It's not predictable as to who gets fat necrosis. Thankfully, it's not particularly common, but as my father's doctor once explained to him, my father was getting cancer treatment, and they go over all the risks and the complications, and he was saying like, oh, 1% chance of this, 1% chance of this, 1%, 2%, whatever. But then he said, or she really, Dr. Vickers, who I love, she said, well, if it happens to you, it's 100% chance. And so I thought, that does make a lot of sense. So complications, you know, they can be low, and the complication for fat necrosis, I would imagine, would be in that 1%. We don't have data from studies to show, but in my experience, it probably would be about 1%. But if it happens to you, that 1% is 100%, and it's kind of miserable. It looks like an infection, and if you look at an infection, we've all had some type of infection or ingrown hairs or boils or whatever. And infections are all the same. They're red, they're hot, they're swollen, and they're painful. And the fat necrosis can look like that. It can mimic an infection. It's not an infection, but it can mimic it. And the reason I know it's not an infection is I've treated patients with every single antibiotic under the sun to no effect. I've cultured them. When I actually used to drain them, I've taken cultures. They didn't grow any bacteria, and it's just fat that has not got enough oxygen, and it didn't survive, and it became calcified, and that's fat necrosis. And then your body will start to extrude it, so it'll start to push it out towards the skin, and when it does that, it gets red and swollen, hot, and hurts, and looks like an infection. So if you go into an emergency room, then I guarantee 100% surgeon on call will say, oh, well, that's an infection, and the treatment for that is to put a knife in it, open it up to let the infection out. It's not really necessary when you have fat necrosis because your body will heal it on its own. So areas of fat necrosis, they will heal on their own when untreated. untreated. So that's how I do it. And I think for patients that will have surgery, I've seen patients and other patients come in and they had surgery and they can be left with a divot there. Whereas if you just let it heal on its own, it doesn't affect your contour at all. Surprisingly enough, but it doesn't. Okay, let's talk about the skin. The skin is something that's very important to me. And let me just remind you at this point, could you clear some of that stuff once? So let me just remind you at that point that hang in there, because I'm going to give you a QR code and you can download this guide, which I have all my patients read, and it's really important for the caregiver to read. So if you're having surgery tomorrow, is anyone having surgery soon? Anybody having a BBL soon? That I would like to know that. But anyway, if you are, then you're not only are you going to want to read this guide, but your caregiver is going to want to read this guide. In fact, I have a whole section here made specifically for the caregiver and for and also for the post-operative instructions. And so it'll really help your caregiver to read this, and they'll know all the things, because after surgery the patients are not really in a shape to look after themselves, and your caregiver needs to be educated. You need to be educated, but then you need to get something here for your caregiver so they can know what's going on and look after you. And in fact, I have guides for a lot of things, and I'm still working on them. And Frankie thinks I'm taking a long time, and I am. But I'm writing them myself, and they take a long time to write, and they're very comprehensive. So I have a guide now for BBL, for tummy tucks, for breast reduction, scar care, and for liposuction. So these are really useful, good information to get educated. And I think that's something that as doctors we don't always do the best job of. Okay, let's talk for a moment about fibrosis, because this is a big passion of mine, because I can't stand when somebody has a really nice result and their skin doesn't look good. It just kind of, it's like somebody, it's like that TV commercial I used to watch all the time when I was watching the NHL Network during the playoffs. I'm kind of a hockey fan, and there was this. It was advertising, I think, the NHL app, and it was so captivating that this man was watching the app, and then the little kid was having a party, and then the little kid had a piñata, and he came over and started beating the hell out of his cake. And so, to me, that's like somebody taking a baseball bat to your birthday cake. I mean, this is just ruining it. And so, fibrosis is an enemy of mine, and that's why I was talking earlier about J-plasma. But anyway, there's a few ways that you can prevent fibrosis. You can't treat fibrosis. Why can't you treat fibrosis? Because it's scar. It's just like this. And people say, well, just lipo it out. You cannot lipo it out. You just simply cannot. It would be like me trying to take my liposuction cannula and trying to go in here. It's physically impossible. Now, you can have fat that's still there, and what happens is that fat is kind of locked in a cage of scar tissue. And so, yes, there's fat, and you can even feel like, oh yeah, there's fat there, and you can't get it out. How do I know? Because I've tried many, many times. When you're starting out and someone comes in and they have an area and you think that's fat and there's no scar around it, and they say, oh, I don't like this. You're like, yeah, I don't like that either. Let me go take you back to the OR and see if I can get it. And you go into the OR with all these great hopes, and then you're going and you're trying to do this, and you're like, oh my God, I can't do it. So you can't treat fibrosis, but you can prevent it. And you can prevent it by activating your lymphatic system to open up the lymphatic channels. And if you think these models are good, I got a really good model coming for the lymphatic system. And because I want people to understand this concept, is why I'm in love with every single manual lymphatic drainage therapist. I think these are people doing just yeoman's work. They're so helpful, and it's opening up the lymphatic system. So I have my patients roll. We're not going to go crazy about the roller, but the roller activates the lymphatic system. I have my patients use FibroGuard because that activates the lymphatic system. The lymphatic system gets the fluid out gets the swelling out, and it gets all those little inflammatory mediators that are there that are creating the scar tissue, and it gets them out. That's why you don't compress for longer than those 2 weeks. You're compressing to prevent the seroma. But if you continue to compress, you're going to close down the lymphatic system, and we want the lymphatic system open. We want the lymphatic system open to be able to get those inflammatory mediators out, get the fluid out, and get the tissue soft so we don't have lumpy, bumpy skin after. Here's a little video
When we perform
that will
liposuction,
explain this. And that shows the installation of the fluid. That's what we do, and that makes it easier to remove the fat. And these are the cannulas that go in, and they literally just suction out and suck out this fat. And then what you'll see is that white squiggly line right across the middle. That is the fascia that can get scarred and get that scarring and create the fibrosis. And the skin above it is tethered to it. So whatever happens here happens in the skin level. And so if you get that scarring there. So that's why I use the FibroGuard, which is these little foam spheres. They go onto the abdomen. You wear it underneath your faja. Starting 2 weeks out, when you remove the boards and the foams, you wear the FibroGuard. That activates your lymphatic system, and that removes the fluid, and that gives you softer fascia, and that prevents fibrosis. And I don't have a clinical study to show it, but I can tell you I have a lot of experience with it, and I think that aside from the faja, it's the most important thing that you can do for the quality of your skin after liposuction. And I use it in my tummy tuck patients too, and it gives really nice soft supple skin, and so it's very easy. It just goes on as a waist trainer, and it has these little foam bubbles, and you just wear it underneath your faja. So, okay, so speaking of that, let's talk about the Ogee recovery protocol. The protocol has been designed so that you can really get the best skin and get the best result after surgery. And I can tell you that if you ask most people, how long should you wear your boards and foams? They'll say 1 month. Well, how long do you wear this? Oh, this. And they're just answers that are not really. Oh, I just thought of something. I do have a little teaser coming up. This is good. This is really good. Okay, keep that in mind. It's coming. Teaser. Ooh, I'm very excited about it. I'm very excited about the recovery protocol, though. But you know, there's just these answers like, oh, 1 month is. There's no real logic, science, reason behind it, or experience behind it as to why you're doing things. So that's why I like to do things in an organized manner, like my protocols. And so you can't see me, so good for you. But I'm just going to tell you about this protocol. I'm not going to dwell on it, but I tell patients when. Is this good?
Yes.
Okay.
This is straight.
Huh?
Straight to the camera.
Oh, this way.
Yes.
Okay. So, what do you mean? You can't see this? So, okay. So the Ogee recovery, the protocol is set up. Where does it start? It starts over there, right? So the protocol is set up, and I tell patients when they come in, I say, this is, I've got this all worked out. There's nothing really for you to do. Just get on the bus. We'll take you where you're going. And this is the bus, because it starts off, it tells you what you need to do at different times, how long to do it. So I'm not going to go through all of it in detail. It is in the BBL guide. There's a copy of this. And so it goes through, and it'll tell you how long to wear your faja, your foams, your boards, the roller, the FibroGuard, how many massages you need. All these types of things are in here. And this is what I have my patients follow, because since I've been doing the Ogee protocol and the way to recover, not my skin, but the patient's skin has been better. It's noticeably better. And so there's a lot of misinformation out there, and there's a lot of things that are not based on what's working. It's kind of based on how things have been done. And I don't think you're going to want to wear a board more than 2 weeks, because why are we wearing the board? We're wearing the board to prevent a seroma. Seromas typically form within that 2-week period. So there's no need to wear them after 2 weeks. And in fact, they're harmful because of that overcompression. So the protocols here, you should use it, in my opinion, to get the very best skin. But this is what I have my patients do. Okay. I do have a little teaser coming up, but before we do that, let's talk about, now who are these people over here? Why are they here? Who are these people? Oh, these are the hip dips. Okay, we're going to talk about the hip dips in a second. I'm going to talk about hip dips, but first, let me take some questions. Do we have time for some? Yeah, we got time. Let's take a few more questions here. And then after questions, I've got something super important to show you. It's not out yet, but it's coming. I think it'll be. I'm hoping to get it out in the late fall. It's really exciting because it's actually going to improve fat survival. But I'll show you that in a minute. I'm super excited about that. But let's take a few. Donde mi preguntas? Okay.
And just start at the bottom. So
Start at the bottom, okay. Because I think it wasn't updating when I was doing it before. Okay, let's do that. All right. Let's say Miss Munoz saying, I had a tummy tuck a year ago, no lipo. Now I want to do a BBL. Do you perform lipo between the belly button and the tummy incision? Yes. I'm wondering if you're asking that question because you think it's not safe to do that because of a blood supply problem, maybe. I'm not sure. But, yeah, so the best way, and I'm going to be making a video about this tomorrow, actually, but the best way to do it is to do a tummy tuck first, like you've done. That gets rid of the skin. And then we will go through and do lipo after, and I'll lipo everything and do the, if you want lipo, fine, or if you want lipo and the transfer to BBL, that's fine too. It's safe to do it, but you have to wait at least 6 months after having your tummy tuck in order to have the lipo or BBL, because you have to have that blood supply after the tummy tuck reestablish itself. But if you can follow me here, I'll tell you another reason why a tummy tuck is better to do first before a BBL. So when we do a tummy tuck, let me just use one of these models here. Okay, when we do a tummy tuck, right, we lift this up and we go through, we tighten the muscles and we bring the skin down, we cut off the extra skin. Now, if you have quite a bit of fat in this upper area, I will lipo a little bit of that fat. I can't lipo as much during the tummy tuck as I can after a tummy tuck. But I like to take a little bit because it can reduce that thickness and make your result of the tummy better. So I'll do that. But for patients that have quite a bit of fat in the upper abdomen, if I can only remove a little bit of that when I do their tummy tuck, they're still going to have some fat up there after their tummy tuck. But if we go through and do their tummy tuck first, and then we plan to come back 6 months later and do their lipo or their BBL, then I can go through and lipo extensively all of that area, and that will get you as flat. That gets you the best result. So it's another reason why some people are better off, well, I think most people, but particularly some people are better off doing a tummy tuck first and then doing their lipo or BBL. Tammy Holder, what is the stigma about the smell of BBL? Well, you are a latecomer, Tammy, because you missed it at the very beginning. And this is our newest product we have in the Ogee Recovery Store. This is for your husband or your boyfriend or family members at Thanksgiving to wear this so they can put up with your smell from a BBL. It's a hoax. It's not true at all. And believe me, I've done quite a few BBLs. And if there was a smell, I probably would have stopped doing the operation because I couldn't take the follow-ups. I would have been like, oh my God, another follow-up? Oh, okay, let's go see the follow-up of the BBL. Oh, it's a breast augmentation? Okay, never mind. I don't need my mask. It's just clickbait. But you know how things are in society or social media, and something becomes like an urban myth. So somebody has said that BBL smell. If you don't wash down there, you're going to smell. I think that's pretty well understood. But having a BBL does not generate any smell. We're taking fat from one area and we're transferring it to another, and that fat just becomes your regular fat in your butt, and that doesn't generate any smell just by having that. So that smell is a myth, but I'm sure I'll probably have to say that many more times because people sort of believe that. Ashley, fibroids leaving creases is normal. Will they go away? It shouldn't be giving you creases, but it should be giving you little divots so that you look like, when you take your FibroGuard off, you look like you're a golf ball. And that's normal. And that's why we have you wear the FibroGuard for 12 hours a day. Don't wear it longer. Don't put it on too tight, because if you put it on too tight, I think the tendency is for people, anything, waist trainer or whatever, to put on things too tight, and you don't want that because we don't want the compression. We want that to be nice against your skin. Just make it comfortable so that will open the lymphatic system. Okay, Desiree Park says, I had lipo last year but no BBL. Would I have enough fat for a BBL? I have some fat in my back, still in my thighs. Well, typically, yes, I do a lot of round 2 BBLs. Usually there is some residual fat. I will say that it's not as common in my patients to have residual fat, but it's possible for them as well. But usually what I see for patients with a round 2 that I didn't do the original surgery is they have a lot of fat, a lot of lipo in the lower back, or to get like a waist, and then there's less fat removal up top. And it's more difficult to remove the fat up top because it's more fibrous fat. And so I think there's just a tendency to focus on that. So quite often with a second round BBL, patients will have quite a bit of fat, and I lipo all the way up. So there's usually fat there. We can add arms sometimes if you need to. Sometimes people have residual fat all over. And so it's usually not difficult to do a second round BBL. Although I don't want to say everyone can have one, but most people that I see are candidates for a second round if that's what they want. Rosemary, God bless you. That is so nice of you to say that. I don't think it's true, but I appreciate it. Carlos, so what do you recommend me to do before my surgery with you in December? Okay, then just hang around and download this guide, because you don't even need to be here watching me talk. It's all right here. It's all right here. Everything you need to know, from soup to nuts, all right there, and it's got the protocol as well. Kayla says, I got a breast reduction last November. Is a BBL safe? Yeah, they're not related at all. And as I mentioned with the ultrasound, BBLs are safe operations, despite everyone saying like, oh, it's the most dangerous operation. And they quote the 1 in 3,000 people die. And that's no longer true, that it's not a dangerous operation. And it's not related to your breast reduction anyway. So no problems there. Jasmine, are there marks noticeable from the lipo incisions? Yeah, you can see the scars from the lipo incisions, but they're very small. And they tend to fade, so people really don't usually complain about lipo incision scars, and they're not really that noticeable or that big of a deal. They don't really pose much of a problem. Keani Fraser's, can I have a tummy tuck after 5 C-sections? Can I say something? You deserve a tummy tuck after having 5 C-sections. Good Lord. You are a trooper. So yes, you can have I had a patient a couple weeks ago. I think she had seven children. Now Now those were natural, but still, that C-sections, that's a common question, and I know it's a BBL live, but we'll just talk about the C-section tummy tuck for a moment. So the C-section, what does it do? Well, they make an incision in your muscle to go down into the uterus to remove to deliver the little baby. And whenever you operate anywhere, the body heals by scarring, scar tissue. That's how your body heals, except for the liver. The liver will actually regenerate. You can cut out half your liver, give it to your niece, and your liver will grow back. And that little piece you gave them will grow into a big liver. So the liver will regenerate, but every other part of the body heals by scarring. So when you have a C-section, you'll have a scar in that muscle. And when I do the tummy tuck and I'm raising the skin and fat off of the abdominal wall, off of the muscle, and you've had a C-section, then I'll just have to cut through the scar tissue. But it doesn't really change anything, or it doesn't really affect anything. It's just a little bit of scar tissue where the skin and the fat are more tethered to that abdominal wall. But once I go through that scar tissue, then everything's just normal. So having a C-section does not affect you having a tummy tuck at all. Katie Bug, I always recommend people stay at least 7 days post-op if they're coming in from out of state. It's a big recovery from a BBL. The first 3 days are like a storm, and then the storm starts to pass. It's very difficult. That's why you need to have a really well-educated caregiver. Your caregiver needs to read the instructions, the post-operative instructions. They need to be well-informed to care for you. It's not the type of thing where you're having surgery on Tuesday and you're like, call someone on Monday like, hey, can you look after me tomorrow? It's much more complicated than that. And if you stay for a week, then we do all the massages in the office. And so you can have massages in the office, and then you're coming to the office every day. If you have a seroma, we can just drain it right away. So if you leave after 3 days, it's dangerous to leave because you're going to higher risk of developing a blood clot in your legs. And it's also going to be problematic with your traveling and putting pressure on your butt. And if you develop a seroma in that early period, then you don't have anyone there who can treat it. So if you stay here a week, we can really take good care of you, get you all bundled up and packaged, and then it's safe for you to go. Amel Caddy's asking, and I know this is not BBL, but I'm just going to go through and answer them. Can you still breastfeed after breast lifting or breast lipo filling? The answer to that is yes. Annie Valdez, is it absolutely not recommended to have a tummy tuck and BBL at the same time? I do them at the same time. I try not to. I try to tell patients, listen, do your tummy tuck first and do your BBL second. I think it's a better way. It's an easier recovery. It's difficult when you do tummy tuck and BBL together because with a tummy tuck, you can't lay on your tummy. And that's exactly how you have to recover after BBL. So you have to lay on your tummy because you can't lay on your back and you can't lay on your sides. So if you can't lay on your back, your sides, or your tummy, how do you recover? Now, some people do. They use a BBL chair with a cutout in it so they can stay flexed after having their tummy tuck and not put pressure on their butt. I think there's still pressure put on your butt. After saying all of that, have I had people who have had tummy tucks and BBL and turn out really well? Yes, I have. But I do think there are more problems, some healing problems with the tummy tuck related to it. So I try to get patients to separate them, do tummy first and BBL. Carlos, where can I find the post-op recovery guide? Yes, this is what you need. Hang on. I'm going to give you a QR code. I'm holding you hostage to get this. But actually, the next slide on here is going to be something that I guarantee you that you're going to be interested in because it's really cool. And I don't want to get into too much, but I got to tell you because I just can't keep it under wraps anymore. How long does it take to heal completely after BBL? It's a very good question. If you really want to say, well, how long totally? It's a year for all the swelling. Now, are you going to have to wait a year before and after? No, you're not going to. The swelling, the way the swelling works, I'll just draw this here quickly for you. The way this swelling works is, here you are, let's say you have surgery right here, and you have normal, no swelling here, and then it starts to go up rapidly, and then it'll peak, and then your body will slowly get rid of it over time. So as far as what this time course looks like is, let's say this is day 0, so that's your day of surgery. And this peak swelling here is actually only 3 days. And then as this fluid starts to come out, you get a significant amount of fluid. So all of this fluid would be removed by about 3 weeks. And then at 6 weeks, you have another fairly significant change. So you'll get a lot of fluid out by 6 weeks. And you'll have a lot of what your shape will look like. But it's not totally your final shape, because up to 12 months here, you'll have this remaining fluid will come out. And that remaining fluid, 5% or 7% or something like that, that remaining fluid will just kind of be coming out of your skin as well. And that's really when your lymphatics are working to get that. So it's kind of like, the analogy I use is if you have a kitchen sponge and it's totally soaking wet, that's like your 3 days. Then you give it a pretty good squeeze, that's like your 3 weeks. And then you leave that kitchen sponge just on your windowsill. The sun's coming in and that thing gets dried out, and by 6 weeks looks like a little, a little, I don't know, what am I saying, like a little, I don't know, chip or something. It's really dried. You know when that sponge gets really just desiccated? That's kind of like the 12-month mark, where just there's bone dry, there's nothing left. And 6 weeks is kind of when it's pretty dry, but there's a little dampness to it. So that's how long it takes for the swelling. Ebony, can you request drains if you don't use them? You can, but I'm not going to use them. And I've worked a very long time operating on many, many patients to come up with the way I do things. So I do them the way I do them because I think that's the best way to do it, at least for me. I don't tell other surgeons not to use drains or you can compress for 3 months, whatever you want, whatever they do, that's fine. But for me, I do it the way I do it because I think it works well. So I don't use drains. I don't think they're beneficial. I actually think they're, in my opinion, they're not helpful. So I don't use them even if somebody would want them. Draco says, why has my BBL shrunk after 2 years? I would imagine it's weight loss. That would be really the only reason for a BBL to shrink. Once all the fat has survived, then the BBL, the fat there, it stays there. But it's a fat cell. If you gain weight, it gets bigger. If you lose weight, it gets smaller. But once that fat has survived, and that's usually kind of, we get into the fluff fairy, and that's why, can you influence that survival for longer than the first month or so? You probably can, So anyway, but once all that fat has survived, then if it's going to go away, it's only going to be because of weight loss. There's no other way for that to happen. Am I only in Miami? I am only in Miami. I've never operated in Orlando, but I think, I'm not 100% sure, but I think that's our next Ogee Roadshow destination is Orlando. I'm thinking like in the fall. Is a pinched nerve dangerous for getting a BBL? I'm not sure what nerve you're talking about. If you're talking about sciatic, pinched nerve is kind of not a medical term. So I would just say see a neurosurgeon and make sure that all of that is functioning well. If for people that do have sciatica or back pain that's non-operative, there's nothing for them to be done, or they're not at risk for having any problems, they will usually have a flare-up of that after having a BBL because of their positioning for recovery, having to lay on their stomach to recover. So It's usually not an issue, but you want to make sure that you don't have some issue with your nerve. So I would get, yes, Katie Bug, the Ogee roller. It's not being discontinued. It's just that it's manufactured in China. So these tariffs, I mean, they come and they go, and it's very unpredictable. And the Ogee roller is very expensive. People complain about the price, and I understand that, but it's expensive to manufacture. And so if we order it on one day and then it arrives and then there's a huge tariff, then it would just be cost prohibitive. I've charged $500 for the roller to be able to, accommodate that tariff. So I haven't placed an order for them until maybe we get some stability. But so what I have, or I don't really have them. The Ogee Recovery has them, and I don't even run that. But they have whatever they have, they're going to sell, and when that runs out, that unfortunately will be the end of it, because I love the roller and it works really, really well, and I know patients do. And the roller is nice because you can keep it. I have a roller myself that my wife, God bless her, will use on me. I use it on her too. Like it's really good for rolling the calves, if I can tell you, just the shape of it. So it's a great roller. You can have it after your surgery is finished. You can use it for other things. So I really good. Obi Quinn, do I give Exparel shots? No, I don't. The reason is because if I did, I would kill you. And I'm not about that. And the reason I would, without going into a tremendous amount of detail, is that the fluid that I use to instill to do the liposuction has lidocaine, which is a very effective local anesthetic. It provides pain relief for 24 or 36 hours after surgery. That lidocaine is actually still effective. But if you use Exparel with lidocaine, you can die of a toxicity, because what happens is the lidocaine can bind to the Exparel, the little phospholipids, and it can release the other bupivacaine that's on the Exparel, and that can give you a lethal dose. So I do not use Exparel for my surgery, because I usually am using lidocaine. Okay, Sharon Carroll, I haven't answered any of your questions. What's your question? I don't see it. There's a lot of questions here. I haven't seen any message. So you type it in there. I'll answer it. I'm working as fast as I can. I'm doing the best job that I can. There's a lot of questions. I'm trying to go through it. I got slides. I got models. I got 3D. I got this guide that I keep bringing up. I got the other guides I'm talking about over here. I mean, I'm busier than a one-legged man in an ass-kicking contest over here. So give me a little slack here. All right. I can't even remember who asked that question. Oh, it's Sharon Carroll. Show me your question. I'll ask it for you. All right. Great question, Drake Jackson. Cheryl, you're in London. I love London. It is absolutely my wife's favorite city. Every single time she's like, wants to go on vacation there. But ask me a question. I will answer you. Let's see. When was I going to ask? Oh, the Drake Jackson. How long after BBL recovery can you start working out? Great question. You can start working out. For me, my patients, as soon as you want to. So for liposuction patients, I have zero restrictions. They can do anything they want, whenever they want. You're not going to damage your surgery results from liposuction by working out, by doing anything. With a BBL, the only restriction I have on patients is no sitting for 2 weeks. Then they sit on a BBL pillow for 2 weeks. But if they want to go and work out at 3 weeks or whenever they feel like it, no problem. Working out is fantastic. And I say something stupid, but the faster you recover, the faster you recover. Meaning the more you start to get active and start returning, then you're just going to get back to your life. So if you're at 2 weeks and you feel like working out, you can work out. I can tell you for damn sure, you're not going to want to work out at 3 days after, because you're going to feel terrible. So the body your body will tell you when you're capable of working out. I think it's kind of like me saying, if someone's like can I work out at 3 weeks? And if I say, I'm trying to advise them, I think that to me is sort of like telling somebody, hey, don't put your hand in a hot flame. I'm like, yeah, I kind of got that because I go there and it's going to burn me. So it's same thing. Like you're not going to damage your body. So whenever you feel like working out, you work out and no problem. Same with sex. As soon as you want to have sex, no problem. Whenever you do that. Now I've got this London lady in my head. Oh, here she is. Okay, what is the best diet for visceral fat? Oh my God, that's the question we've been waiting for. Why would you ever ask a fat person how to get rid of fat? Sharon, what are you talking about? I can tell you, I have lost 55 pounds. I don't know if you see my svelte face now on YouTube. I got about another 50 to go, so I'm still going. But I'm using, if I can be so bold to share this personal information with you, I'm using Manjaro, and it works wonderful, and I love it. And the first fat that you burn is internal fat, which is why my massive abdomen is starting to shrink down. And somebody the other day, who may be over behind there, told me that I looked kind of just like a normal fat guy now, not like a really big fat guy. So whatever you can do to burn internal fat, I'm a big fan of Manjaro because I'm taking it, it's working well. But essentially what you're going to want to do is just clean eating. The reason why we have like a lot of this obesity is because of these processed foods that are very, calorically dense and everything else, and they tend to accumulate in the visceral fat. So eating a very clean diet. And diet is more effective at losing weight than exercise. I know a lot about losing weight for somebody that needs to lose a lot of weight. And if you think of this, and this is true, is that if you eat one M&M, it takes you, and for you in London, that's a Smartie. So if you eat one Smartie, or maybe two Smarties, a little smaller than M&M, in the United States, everything's bigger. So if you eat two Smarties or one M&M, it's going to take you 100 yards, or for jolly old London, 100 meters to walk off those calories. So what is easier, to eat a bag of M&Ms or Smarties and then have to go run 8 miles, or to be able to just not eat them? So diet is more effective, and that's in visceral fat is the first thing that your body burns. Real talk with Cash, you're not talking real talk. When you made that comment there, I'm pointing you out, I'm calling you out. That's not real talk. Okay. Oh, I told Sharon said, you told me to lose 25 pounds, but I'm trying, it's not going away. I would talk to your physician about using one of those medications, Manjaro, or Manjaro seems to be really good for me. So, and it does have more effective weight loss than Ozempic from what I've read. I'm certainly not an expert in those medications. This fits in well, Louisiana to Texas. What's Dr. Williams' maximum BMI? You're talking to me. What's my maximum BMI? This is the exact opposite way that you should be thinking about that. So you got to get a total 180 in your thinking. That question basically is saying, how fat can I be to have surgery? Well, you're not going to get a good result, and it's going to be riskier if you're not at a good weight. And so you want to have a flat abdomen, you've got to not have visceral fat. The BMI to me is not relevant. It's helpful for just a general thing. There's a law in Florida, you can't do BBL on somebody with a BMI over 40. I would never do a BBL on somebody with a BMI of 39 because they're not going to look good. And I'm not going to just do surgery if they're not going to look good. So whenever I say, oh, you need to lose weight, I'm not being mean to you. I'm not being punitive to you. I'm not a fat shamer. I'm just simply trying to get you the best result. And if I see that you have visceral fat, which I cannot take, that's fat on the inside, and I can't take that fat, then I know you're not going to look good, and there's no point spending the money, there's no point going through the recovery, there's no point doing all of these types of things if you're not going to get a good result. And let's see, What should I weigh, Erica? I don't know what you should weigh. It's not based on our height. It's not based on the number. It's really based on whether you have visceral fat, which is internal fat, or you don't. And so here's a good example. Let me see. I'm sort of bothered. Can you grab that the chicken for me? I'm gonna show you this model. I don't know if you've seen these before. Just the pollo. Okay, so here she is here. Okay, okay. So here, would you want me to do it this way? Okay, huh? This way. Okay. So we're talking about visceral fat versus internal fat. So you might say here so if you've just joined me, welcome. Tell me where you're from. If you just joined me, you might say, and even our good friend in London who we've been teasing, and I know it is late there. It's what is that? 9 plus 8. So yeah, that is pretty late. It's like 5 in the morning, I guess. So if you're joining and you see this patient you're like, well, what in the world? Why is he telling me that I need to lose weight? Because this person here has a lot of fat and she looks good afterwards. It's because this person had all external fat. And so when you do lipo, I can remove the external fat. I can't remove the internal fat. So that's the reason why, if I'm asking you to lose weight, it's not related to the BMI. Don't think, what is the biggest BMI I can have? Think of, how can I get my internal fat, the visceral fat, that cannot be removed with lipo as low as you can. That's how you're going to get the flattest stomach. That's how you're going to get the very best result. Erica Slaughter, I do not know. I don't have an answer to that question. I'm sorry. And sometimes we don't have answers and don't know. But that is unusual. I haven't heard of anyone still having that type of pain 5 years after. So I would talk to your surgeon. It's a good question, Nicole. Don't fall into this trap. Will I lose fat if I go to the gym after my BBL and then I quit the gym when I lose? So a gym working out, I think people think if they're on the Stairmaster or they're a treadmill or whatever, doing squats maybe, I'm not sure, they think that, can you put our exercise video link? We're going to put an exercise video link on here. I've got an exercise with a personal trainer who's really, really good and did some exercises with one of my patients and showed a whole program of exercises to do before and after having a BBL. But you're not going to lose your fat from a BBL. Once that fat is there and it's attached and it's growing, it's your fat. And just because it was transferred, those fat cells have no idea that they started out in the key area and ended up in the butt. They have no idea. They're just fat cells. They're just living there. So you're not going to automatically just lose fat because you had it transferred there. That fat is there. If you lose weight, yeah, you're going to lose fat. You may lose more fat in your face, or you may lose it in the visceral. It doesn't mean that you're just going to all of a sudden lose your butt fat. So you can work out and don't have any concerns that you're going to lose your BBL. Nils, yes, if you have a vertical C-section, you can have a tummy tuck. Doesn't make any bit of difference at all to tummy tuck. And again, I deal with a lot of patients that grew up in Cuba, and a lot of them had these vertical incisions for appendix operations, for C-sections, hysterectomy, and have a vertical incision instead of our traditional fan and steel horizontal incision that gets done in North America for C-sections. But having a vertical scar doesn't make a difference, and it's nice. We can usually cut all of it out, so it makes a big deal. Big difference. Paolo, remind me to make a video on that so I can explain that a little bit better. Carlos, what supplies do you recommend getting before your surgery to be prepared? All right, Carlos, you're starting to really piss me off here now, because I'm telling you, it's all in here. It's all in Here, just hang on a second, and I'm going to put the QR code. Believe me, this has all the information you'll need. It's going to tell you what you need to get, what supplements to take before for your blood, everything. So just hang on, give me a moment. They're coming in fast and furious, and I'm trying to get at them here. Okay, True Consulting wants to know, how do you know or measure the difference in internal versus external fat? Can I just tell you, this is the most difficult thing for me to explain. It's so easy for me to make the determination when I see the patient, but it's very hard for me to explain it. I really will have to say, there are some good videos that Oscar has made that demonstrate really clearly internal and external fat, but it still is hard for me to tell patients, how do you make that assessment on their self? All I can tell you is like a Pillsbury Doughboy, if you kind of poke in there, and as you're poking, you'll feel you're on the skin. Okay, you're on the skin here. That's your skin, and then as you poke, that's your external fat. And as soon as you stop poking, as soon as you feel that softness go away, and you hit something firm, that's your abdomen. That's your abdominal wall. Those are your muscles. And anything behind your muscles is internal, and that's the visceral fat. And that fat is in places like your mesentery, the lining of your abdominal and pelvic cavity is called peritoneum. It's around your organs. It can be in your liver. And that fat, as you go and you hit the abdominal wall, we do not enter the abdomen. We do not go in the abdomen for any operation. If you have a plastic surgeon and they end up in your abdomen, that's a problem. So we don't go inside. And you couldn't go in and remove the fat anyway, because if you lipo the liver, you're going to kill the person. So visceral fat, it's hard for me to explain it, but if you can also see somebody that has a very big rotund shape, usually that is poking out because of internal fat. Annie Valdez, do I use the Vaser technique? I don't, and just because I mentioned it earlier when I was talking about J plasma, it generates more scarring, and I am allergic to fibrosis. I don't want my patients to have fibrosis, so I don't want anything that's going to increase the chances of them having that. And I think that anytime you apply heat when you're doing lipo, I'm going to answer 10 more questions. I'm going to show you this first, and this is really kind of cool. And then Carlos, it's coming for you. This is going to be the guide. But before that, look at this. Look at this. Just look at it. Look at this. This is coming in the fall, probably late fall, and this is called Fat Vive. It's a supplement to take, and it's been shown in animal studies to improve fat survival. And so that's coming, and I'm super excited about this because I think this is going to be quite a game changer. Okay, we're talking about questions. Let me fast forward to this. Here's a QR code. And are we going to have a link? We always have this question. So anyway, if you're watching this on your TV or on your laptop, just use your phone and scan the QR code. If you're watching it on your phone, then we're going to put a link in here where you can download this guide. I want you to have this guide, and you'll download a digital copy. I do have hard copies that I give patients as well. This has everything in it that you need to know, aside from the book that's coming out too. That's going to be coming out probably in the fall as well. That's going to be more of sort of anecdotal stories and a lot of the reasoning and the theory behind what I'm doing. But this guide is a distilled version of that. The book's going to be quite a bit bigger. And this guide, though, is really good. It's got a lot of information. And I would encourage you, if you get the guide and you use it, and there's a question that you have, and you're like, hey, you didn't put that in your guide, just tell me, because I would like to put it in the guide if it's something that I think is good. If you have a good tip, I mean, you have to remember that I'm the one sitting here spouting out and talking my head off and telling you all this information. Oh, look at how smart I am, giving all. Where did I learn this information? I learned it from you. You taught me the information. Everything I know about recovery, I learned from my patients. So if you have a tip, if you have something that works well for you, if you see something that I've written, you're like, actually, I got a better way to do it, tell me. I would love to know. And if I think it's good or makes sense and we do it and it works, I'll put it in the guide. The guide's a digital thing. We can edit that any day. So I really like the guide and I want it to be comprehensive. So, okay, I'm going to finish up. I'm old, so I'm thinking like TYSM. What is that? Oh, thank you so much for this guide. You're very welcome. It's my pleasure. Please, by all means, use it. Let's see. Apollonia says, I had to gain 30 pounds. I don't usually tell patients to gain weight, and I don't know that I've ever told anyone to gain 30. And now my face is fatter. Is it possible to add chin lipo or buccal fat removal? No. If you didn't have that before you gained weight, just lose the weight, and we don't have to do surgery. You shouldn't gain weight and then now we're going to remove that. You don't need to do that. Just afterwards, use it. Seven Chase. This is the alloplate. Does that appear the way it is, or is it backwards? Okay. That's how you spell it. I will be doing a live event on alloclay, but it's so new that I need to get experience with it before and make sure that everything's working exactly the way it is. I think it will. And so I will talk about that more later. There's just not a lot of information. There's not a lot of doctors that have access to alloclay right now, so you'll see some sparse information out there. But I'm going to be going through all of the science with it and explaining it in great detail, but that's coming down the road. There was a question here. I'm starting Manjaro soon. This is a great sign. Rosemary Dominguez, I don't know if you know, but if you go to Lilly Direct, if your insurance won't cover it, you can get it from Lilly Direct as well if your doctor does that for you. It's how I get mine, and it works out really well. They send it to your home. And in my office, we have Rihanna, who is a wonderful physician assistant. She does all of the laser treatments and injectables and Avelli, and she's wonderful. And she also runs the weight loss program, and so she does injections and blood work and manages patients. And she actually writes me for my prescription. She manages my weight loss as well. So she's really good. And if that's what you would rather do and have somebody, it's really only for people in Miami who can't do this remotely. You need to be here and you need to come and get the injection and things like that. But she's really good. Val AKP, thank you so much. That is really nice of you to say, and I really appreciate you saying that. I sincerely do. I love what I do, and doing a live, it's not a burden for me. I enjoy it. I love to operate. I've seen patients, the whole thing. It's just I like to do this. I feel lucky that I'm able to do it. But when somebody thanks me like that, that's very nice of you. So thank you very much. I thank you for thanking me. Jen P, that's a good question. Is there an actual lifting done, or is it only fat added to specific areas of a BBL? That's a really good question. And the answer is there is no lifting. But guess what the surgery is called? Brazilian butt lift. But there is no lifting. And you have to be aware in surgery there is a lot of marketing. And there's a lot of terms that people use. And who wouldn't rather have a higher butt and a lifted butt? When patients will come in and they'll put their hand down, they're like, well, I'm looking for this. I'll say, well, actually, BBL doesn't even lift the butt. And they're like, it's called a Brazilian butt lift. But I don't know if that's been around. Maybe Dr. Patange. I don't know who named it. But it's that it doesn't technically lift the butt. I think part of the impression comes from when you have a BBL, it can appear that it's been lifted. But technically, you are correct. It is not lifted. We're just adding fat and changing the shape. And for me, anyway, it's really the whole body shape. If we look at somebody here, That's a dent. Where is somebody here to show after surgery? That's before. Where are all my post-ops? There she is. Okay, so here's post-op. Let me make sure these are the same people. Yes. Okay. So for these two people, does it appear that their butt has been lifted? I think the answer is yes. Has it technically been lifted? No. Should I go this way? Okay. Has it technically been lifted? No. It's just fat that's been added to these areas. And if you're just joining me, this is actually a real patient and a real 3D render of her, which is just amazing. I love them. So a BBL doesn't lift the butt, even though that's what it is called. Life with Ogee says, how tight should the faja be? So that's a good question, and every single day I'm telling patients, you don't have to wear your faja quite as tight as you're doing. It just should be there, that's snug. Excuse me. Snug. Sometimes I do get hiccups or burps from the Manjaro. But a faja should be snug, but not overly tight. And so it should be comfortable, really. And it should never be hurting you, or never should blanch the skin, or you compromise the blood supply, or really, pinch things in. You are not going to compress your way to a better shape. You're going to get your shape from the operating room. You need to use compression. You need to manage it. You need all of these things to do to get better skin. But in order to get the shape, that's not coming from compression. What the shape happened in the operating room. So trying to over compress a bad lipo is not going to get you a good result. Esther Bello, do I transfer breast to the fat? I do. Yes, I do. I love using fat in the breast. I'll either use it with a breast lift. Occasionally I'll use it with a breast lift with an implant, which can help to get some of that more upper pole fullness. And sometimes I'll use it with a breast augmentation in patients that have sort of thin tissues, and I can get a little bit of fat, and that'll help thicken the tissue, conceal the implant a little bit more. So fat grafting is really good.
There's actually a video this weekend that will be this Sunday.
Oh, this Sunday night? Okay, there we go. This Sunday night, there's going to be a video on fat grafting to the breast. Is it the usual kind of BTM time?
Yeah.
Sunday night at
around
8 o'clock at night. There'll be a video about breast fat grafting. I did see a question here. Oh, any recovery house we recommend? We do Recovery by Ari, is somebody who we usually recommend. She's top notch. She's hard to get into, though. She books up quickly. And I don't have her information here. Can you, Paula or Frankie or somebody who's out there, can you just remind me to, maybe we can make a story or post tomorrow so we can tell people who that is. Let's see. Louisiana, Texas. This sounds like a compliment, so let me read this as a question, because I'm a delicate plastic surgeon with a frail ego, and I need to have my ego stroke. So let's see what Louise, I haven't read it all, but it looks good. Let's see. Maybe it's going to take a turn for the worse. I'm not sure. All right, Louisiana to Texas. Sounds like a hot sauce. I love your results. The BBLs look so natural, and the Ogee curve in the key area, folks, that makes the bodies look so good. I have two friends that had a BBL with you around 4 years ago. Whoop, whoop. Yes, I'm going to take the compliment. Yes, I like it. Okay, thank you. Cassandra says, although I didn't answer your question, I really enjoyed this live. Listen, you can always email me. My email is somewhere on the YouTube channel, or it's drwilliammiami@icloud.com. Just drwilliammiami@icloud.com. You can email me and ask me any question you like, and I'll be happy to answer it. You can send me photos, whatever you like to do. I am very accessible and very reachable and happy to answer questions. Okay, I'm just going to do a few more, and then we're going to go. Draco says, do I have any specials coming up? Hell no, Draco, I'm not offering specials out here. This takes a lot of work to do this operation. And so, no, I'm not doing any specials. I don't discount my work. I mean, I don't know what you do for a living, but you just discount it willy-nilly? No, I don't discount my work. I'm proud of my work. I've spent a lot of time training. I did 10 years of residency. That's a lot of sleepless nights. So no, I don't do any specials. Okay. Do I treat male liposuction patients? I don't. I don't operate on any male patients. For me, they're more difficult to operate on in terms of lipo. Their fat is more fibrous. Men tend to have more internal fat than women do. And even at the same body weight, if men have more internal fat, women tend to store it externally. So women are better candidates, have better results from lipo for me. And the final reason is because women are very, very, very strong and tough. And if you say, this is going to hurt a lot, and they're like, and you go through and like, oh, how are you doing? What's pain? Well, it's not as bad as when I delivered a baby. Yeah, and you ask a man, what is your 10 out of 10? Whatever you're doing to them at that time. Okay, that's my own bias on men. So that's why I don't operate on males. But my partner, Dr. Caregiver, does a really great job. And he has a very good eye for the male physique and does a wonderful job of male BBLs. And because a male BBL is very different than a female BBL. And so unless you're trying to feminize your male body, you would not want to have the Ogee. That's not a male shape. The male shape, Dr. Caregiver calls this a negative space, and he's talking about sort of the hip dips, which are attractive on a male body. So that's not my area of expertise, and I early on just started to decline to do lipo on men because it was too much work to try to remove that very difficult fat, and there were complainers. So all those reasons, I just stay with the ladies. Louisiana. Okay, here's my email address. It's somewhere on my page on the bio or something, but it's just D. Here, I'll write it down.
No, it's already on the screen.
You got it. Okay, it's on the screen. So that's my email. You're welcome to email me anytime. Okay, that's the visceral fat. That's a problem. I can't really answer that. Yes, I will respond to my email. Of course I do. I have a very tidy email inbox. I check my junk. You know where you get those emails and someone's like, well, I didn't get your email. Well, did you check your junk folder? No, I never thought about checking my junk folder. Of course I check my junk folder. My junk folder is tight. It's clean. So you email me, I will answer you. Joshua, trans people, same reason why I don't operate on males. I don't operate on genetically males because it's too hard for me in terms of the fat and all those other reasons. Okay, let's take one more question. Ava Hernandez, do I do consultations via Zoom? I do not. You would think that would be a great idea and that I would do it, but I've done them in the past, a lot of them, probably about 5 or 6 years ago. And they just didn't work out very well. There was a hard time scheduling from my end and a hard time on the patient's end. And sometimes I would call and the patient would be driving, or it was difficult. But the main issue is that when a patient's on Zoom, there's a lot of movement in the way the patient goes. And I view things in these kind of static pictures to be able to really, and you have to go back and forth with the eye, and it's difficult in live. So maybe I'll change in the future, but for right now, then I don't do that. Final question, Melendez, Sadie, 6 months in between any tummy tuck and lipo, or lipo and tummy tuck, it's always 6 months. Okay. That's it. I'm going to cut the questions off there. I really appreciate everyone watching. It was a lot of fun, and you guys have been a great interactive audience, and it's really fun. If you are still here and haven't said where you're from and you want to write where you're from, I would love to hear that. It tickles me to be able to do that. And I love and a person from London who I was teasing watching. I just think it's great. I mean, in order to benefit from these lives, you don't have to have surgery with me. This is to try to educate you so that you are informed about having surgery. It is really impossible to give somebody a full understanding of any surgical procedure, I think, in a consultation format. There's just too much information to know. So whatever you can do to gain information along the way by watching videos or lives or whatever it is, it's going to benefit you. And honestly, it'll benefit your surgeon as well if you're more informed. When patients come in and they're very well informed, it makes our discussion much deeper because we don't have to talk about like, oh, how long do you not sit for, or how long do you wear your faja, or something like that. Those you really don't need to get that information from a surgeon. That information can be in a book, a guide, a recovery protocol, whatever. And we need to talk about other things and really get to a lot of deeper things. So the more you educate yourself, the better off you're going to be before having surgery. Thank you very much. Trinidad, thanks for adding that in. I will see you next time. I can't see you. What are you saying?
Asking if you're going to save this live.
So say yeah.
Yes, I'm going to save the live. Yeah, I don't know. Those guys are doing something, but they're saving it. They're giving a thumbs up. Live will be saved. Until next time, thank you so much for watching. I appreciate it. You have a great night. And to you in London, top of the morning to you.
Hey, it's Dr. William. Grab your markers.
Have you ever wondered why
Lipo through the key area, round, fill in the hip, blend that into the leg.
I've got my pen and paper out today. I want to talk about.
Okay.
Okay. Yeah, okay. Relax.
Welcome to my YouTube channel.